Well, welcome everyone. Wonderful to see you all here for the first Think Global of this academic year. This is the first in a series, and we thought it was really appropriate to kick it off on what is now yet another global health emergency of international concern. For those of you who haven't met me, I'm Chris Beyrer. I'm the new director of the Institute. And I'm in my third week. So for those of you who are new and just starting in this term, we kind of started around the same time. It's a steep learning curve, but it's been wonderful so far. And I'm particularly delighted to be seeing so many students here, and really look forward to getting to know you all. Monkeypox has been an ongoing epidemic for at least the last 5 years. The emergence probably began in 2017 in Nigeria, which is not an endemic country for this orthopox virus. And we're very fortunate today that one of our speakers, who I'll introduce in a moment, Dina, was the epidemiologist in Nigeria. He and his team really uncovered this outbreak, which, by the way, is ongoing. Maybe we'll put up the first slide, put up the map. But this outbreak, which percolated along for 5 years in Nigeria, did not stay there. And in an emergence, a true infectious disease emergence that we still don't really understand, there then was spread in May, beginning in 2 European countries, in the Canary Islands in Spain and in Belgium, in the city of Antwerp. And both of those events were events where gay and bisexual men, other men who had sex with men, gather. They were pride events, and that is where this outbreak took off. And fast forward to yesterday, these data were updated as of yesterday, where we have documented test positive just under 60,000 cases globally. So that is a pretty remarkably fast spread, starting with a handful of cases in May. Relatively few deaths, happily, but this is a pretty morbid disease that can cause a lot of serious clinical symptoms. Most of the people who've been hospitalized, including the people who've been hospitalized in this country, are actually hospitalized for pain management. It can be an intensely painful infection. So while there's relatively low mortality, there is significant morbidity. And there has been very quickly a lot of social harm as well. And we're going to get into that and talk about some of the stigma issues. This is not the first infectious disease to break out, or at least first be identified in communities of men who have sex with men. And of course, that has been a lasting aspect of HIV stigma, as many of you will know, and here we go again. So we're going to talk about that. And fortunately, we have Greg Gonzalez, who is a real leader in this area, and who also did a lot of really incredibly important early work in HIV. He's one of the founders of ACT UP and a long-standing social activist, and, by the way, a very talented epidemiologist who is an associate professor at Yale. I'm going to introduce him in a moment as well. I think the critical thing to understand about this emergence, we'll talk about it just through the session, is that this has been a significant change in the epidemiology of this virus. So it had been contained largely in Central Africa, Central African rainforest areas. It mostly has been a zoonotic infection with relatively small case numbers, a few hundred cases, really at the most, over many years. This is a change. This change happened in 2017. We don't really understand why. And now those 7 endemic historic countries represent less than 1% of the monkeypox cases. More than 98% of them are in countries that have never seen monkeypox before. That's 103 countries. And which is the country that has reported the largest number of monkeypox cases?
United States.
The United States, thank you. Yeah, we're close to, it's 38% this morning. Just did a back of the thumbnail. So and now, of course, we know there's underreporting, we know there's under-testing, we know particularly the African case numbers, actual cases are probably significantly higher. But nevertheless, we're not doing enough testing either. We have about 30% positivity right now, which suggests that many, many cases are not getting tested. So this is a serious new emergence. It has been declared an epidemic of international concern by the WHO. All three of the people who are on this panel today were part of that decision. And we're going to ask them near the end to talk about what actually went on, because as many of you will know, the panel did not recommend making a recommendation about a pandemic emergency, and they were overruled by the WHO director in what I think is really an example of real leadership. Because if 103 new countries and close to 60,000 cases isn't a new emergent global threat, I don't know what is. So we're delighted to have a really remarkable group of people to speak to us about this, and we're going to ask some questions of them, but then we're also going to open this up for all of you. And first up is going to be Anne Ramoy. So Anne Ramoy, I knew when she was a doctoral student at Johns Hopkins in the early aughts. She's now a professor of infectious diseases at UCLA. She is the only person I know, I think still the only one, who got a K award, a career development award for monkeypox from the NIH in 2002. And at the time, her project officer said to her, "Nobody's interested in monkeypox, rare African endemic virus, why are you bothering?" So follow your passions. Here we are 20 years later, and we are really facing an international epidemic, and Annie is one of the real leaders in this. So Annie, delighted to have you. I'm going to hand it over to you just in a second. I'm going to introduce everybody else and then over to you. Dimi Ogonia is an infectious disease physician from Nigeria. He's a professor of infectious diseases at Niger State University, which was where this initial outbreak, as I said, was picked up. Odimi, there you are. Great to see you. Welcome. He is also the head of the Nigerian Infectious Disease Society. And so we're going to ask him to talk about this emergence and this very different epidemiology that began in 2017. And then our third speaker is Greg Gonsalves, who, as I said, is an epidemiologist at Yale, does a lot of work in infectious disease modeling, has been a very important voice on HIV, but also on COVID-19, both modeling and in policy, has published quite a bit with our own Gavin Ramey on those issues. They got to meet face-to-face today, which was a wonderful thing, but there were a pandemic collaboration, and Greg has consistently been a voice both for human rights, for addressing stigma, but really also for basing public health policy, global health policy on the science. So we're delighted to have you. And Annie, over to you.
Well, thank you so much, Chris, for organizing this. I just think that this is a terrific and timely topic, and obviously something that is very near and dear to my heart. So I'm happy to be here. Just as somebody who's been working on monkeypox for a very long time, it's been very interesting to see how the narrative about this has changed in some ways, but also, we still suffer from the same problems where we're doing a lot of discussion about it, but there still is very little funding available to do anything about it, not only here in the United States, but globally. So I'm tasked this morning as part of this panel, just to give you some context and background. And I'm going to go through it very quickly because we have people here who are going to talk about really what's happening today. But I do want to set the stage so people really do understand how we got to where we are right now. So as you've mentioned, monkeypox up until recently was considered a very rare disease, something that we really didn't worry about too much outside of the African context. It was first discovered in 1958 in a colony of monkeys in Denmark. And this was something that, it was a mystery pox illness that actually turned out to be monkeypox, which is why it's called monkeypox. Now, monkeypox was not considered to be, was very concerning because it was at the end of the smallpox eradication program. And so every case of a pox-like illness was something to be investigated and to be considered. But at that point, it was thought, okay, well, we know that there are other pox viruses in animals, so we shouldn't be too concerned about it right now. In 1970, at the end of this smallpox eradication program, or as this was kind of really ramping up to end smallpox globally, every case of a rash illness that looked potentially like smallpox was being investigated. And even in places like the Democratic Republic of Congo, which were very remote and rural, this was actually happening. And there was a pox-like illness in a 9-month-old child in a very remote village in DRC. Everybody in that household had been vaccinated against smallpox, so it didn't make sense why somebody was getting a pox-like illness here. And so it was the samples were taken, they were analyzed, and this was the first case of monkeypox determined to be in humans. Now, of course, monkeypox was likely circulating for millennia, and certainly being confused with smallpox, because if you're not testing for it, you don't actually know what you're dealing with. So probably there were many cases of monkeypox out there, but nobody was really going to the point of doing diagnostics to understanding what was happening. At this point, there was a WHO program that was launched for intensified disease surveillance. And in the 1970s, there were, with intensive surveillance, 47 cases identified at that point, most of which were in the DRC, but a few cases in other places, including Nigeria. So we knew that it existed. When smallpox was eradicated in 1980, we knew we really had to understand, would monkeypox fill this ecologic niche? What would happen? And so what happened was the WHO started a very intensified disease surveillance system program in DRC from 1981 to 1986. And those 5 years of data are really what most of the information that we know about monkeypox is based on. There were 338 cases that were identified in DRC during this time point. Of course, only in places where they thought this virus was endemic. So that doesn't mean those were the only cases that were out there. Is where you're shining a flashlight is where you're going to see it. But there were a lot of advantages at that time. It was the end of the smallpox eradication program. People knew what they were looking for out there. The physicians that were out there knew how to do it. And they were giving what was equivalent to $90 for any case of monkeypox out there. And if you think about what that would look like today, that's a very big reward for cases. So there is a lot of impetus to be able to be finding these cases. And basically what we know about monkeypox today, up until recently, is really based on those 338 cases. There was really very little done after that point. We heard about outbreaks in DRC. There was a big outbreak in 1997, some of which was also a concurrent chickenpox case. And then from that point onward, we really only saw a few cases. I started a research program in DRC from 2002 to 2007. We did intensified disease surveillance. And what we found is that, we did see a lot of cases, but they were really in people that were not vaccinated, that had no immunity to pox viruses at all. So, we didn't know all that much, but what we could say at that point was, hey, listen, if we're not careful, we're going to continue to see waning immunity. We're going to see people increasingly exposed. And I, in fact, with colleagues in the Democratic Republic of Congo and at NIH, wrote a paper describing this very serious increase of monkeypox far beyond what we anticipated, and said, what we might worry about are things like importation of cases elsewhere. It might get into immunocompromised populations. We might see something else going on here. But we were really talking about clade 1. And there are two clades of monkeypox. One, clade 1, that we see in Central Africa, and clade 2, which is a much less pathogenic in general virus. And in fact, that clade 2 we saw in the United States in 2003, but a very limited outbreak. So I think that gave people the sense that we can control this if we're going to see cases of monkeypox out here. We had 47 cases in the United States. It was all associated with Gambian rats, really animal to human transmission, no person-to-person transmission. Meanwhile, over time, we started seeing more and more of this person-to-person transmission occurring. And we saw maybe up to 9 transmission, or 7 to 9 serial transmissions, but it burned out from that point on. So we really were left unaware of what was happening. I'll just take you fast forward quickly to 2017. There was an outbreak in Nigeria that started that Dr. Ogoina is going to discuss and we're very lucky to have him to tell us about what he saw there. And what he saw there was really something that the world did not take seriously and understand the implications. And from that point onward, we've also seen a lot of importations of monkeypox here and there over time, also something that the world did not pay attention to. Fast forward to today. We now has, as Chris just mentioned, approximately 60,000 cases globally. But what I should say about those 60,000 cases, those are in places mostly that have really good diagnostics. And the way that the WHO has changed their definition of monkeypox, counting cases of monkeypox, you now have to have a laboratory confirmed case. And that means that countries like DRC or other countries in the region that don't have good access, don't have great surveillance, can't get samples, and don't really have the ability to test those samples once they get them, are not able to report cases in this system. So today, we've gone from eradication of smallpox, a few cases here and there, to cases globally, and still very little situational awareness of what's happening in endemic countries. So with that, I'm going to leave you and be happy to talk more later, but I really look forward to hearing what Dr. Ogoina has to say about what happened in Nigeria.
Well, thank you so much, Anne, and Dimi, over to you. And just one thing to say that, of course, you just heard another global health disparity emerge, right, which is testing and diagnostics. Dimi, please.
Yeah, thank you very much, Chris and Greg and everybody for this opportunity to make this contribution and give a perspective from Nigeria. I'll just share a slide just to put some emphasis to what I'm going to say. I assume you can see my slide.
Yes.
All right. So I'll just give an historical account of monkeypox in Nigeria, just an overview. And if you look at this diagram here, you will look at the course of monkeypox in Nigeria over time, beginning in 1971 when the first case was reported, then the second case, then in 1978, the third case. Then we had a gap of about 38 years where no case of monkeypox was reported in the country. Then in 2017, we reported the first set of cases, and that was a period where we had a re-emergence of monkeypox in Nigeria. Do you see the subsequent cases that were reported in the following years? In 2022, there has been an uptick of number of cases, case detection. And if you look at the cumulative case count, you will notice that we have reported more cases in 2022 than we have reported in the last 5 years. And of course, what is also remarkable here is that the majority of those that have been infected are actually males. And the proportion is about 70% males and 30% females. So this just to give us an overview of in terms of distribution. Additionally, we know historically monkeypox is a condition that occurred in rainforest areas. And that was typical in 1970, 1978. The two cases that were reported, three cases that were reported were in two states, and these two states were within the rainforest areas, and those that were infected were actually within the village setting. Although no known exposure, one of them was said to have consumed bushmeat. In 2018, when we had a resurgence, 14 states suddenly had monkeypox. And this was the first time we were noticing that monkeypox was extending beyond the so-called rainforest areas and was also affecting people in the urban settings. 2018, 17 states. 2019, 9 states. 2020, that's the time we had COVID. Of course, just 5 states and a few cases reported. 2021, COVID surveillance issues also affected that. 2022, currently you see the whole country is almost covered. We have just about 4 states that have not reported a confirmed case. So far, could be related to several factors. During this period was also a time that we saw exportation of monkeypox from Nigeria to other countries. And so if you look at this, we had exportations to the US, to the UK, to Israel and Singapore, beginning from 2018 to 2022. And that was the period we had exportation. So what are the modes of transmission of monkeypox in Nigeria? So just to put the context to this. This is just based on the review that was done in 2017-2018 outbreak that was published in the Lancet Infectious Diseases in 2019, and essentially looked at 122 confirmed cases at that time. And you observe here that majority of cases had unknown source of transmission. So the source of transmission could not be established based on the data that was available to health authorities at that time. 30% had likely human-to-human transmission, but only 12 cases had established contact with a confirmed case, and most of them were household contacts. We also had outbreaks within a prison setting. 8% were suspected to have animal contact. Some of them were domestic animals, but there was no exposure to any sick animal or even wild animal. And so that was a picture of the mode of transmission of monkeypox. Currently, we are not too sure about how monkeypox is being transmitted in Nigeria for 2022 because that analysis has not been done. So the first suspicion of probable sexual transmission of Nigeria occurred in our center in my hospital. The index case was an 11-year-old boy that presented to the hospital in September 2017 with various vestibulopostular lesions and ulcers. Look at the nasal ulcers here and very big lesions. So at that time, we suspected monkeypox and the laboratory results came out positive. But what was unusual was that this was not the first case. Indeed, it was not the first case. The first case was actually his uncle, who was 35-year-old and had been infected 3 weeks earlier. That's a scar from the uncle there. And indeed, 5 members of the family got the infection from this uncle. So 5 members of this family were infected. But what we then observed, we were expecting children to report to our hospital. We started observing young adults, predominantly males, coming to our hospital with unusual genital ulcers. And these are examples of genital ulcers of patients that we saw. That yes, some similarities with what we are seeing in the global north, with scrotal edema, lymphedema, penile swelling, and all forms of ulcers, both in males and in females. If you look at these are female ulcers. And as I said, majority of them were young, and some of them had associated syphilis and HIV co-infection. And we published our findings in PLOS ONE journal in 2019, proposing a possible role of sexual contact in the transmission of monkeypox. We have gone ahead to look at the sexual history of some of these cases, and a substantial number of them had multiple sexual partners, condomless casual sex, and also transactional sex or sex with a female sex worker. So that's what we observed. So what is next for Nigeria? Because I'm trying to make this presentation as brief as possible so that we have opportunity to discuss. Of course, as has been alluded to by previous speakers, it's our belief that the number of cases we are reporting in Nigeria and indeed in Africa is underrepresented or underestimated. So there's need to improve surveillance, laboratory turnaround. Of course, we're not sure of the animal reservoirs of monkeypox, and there's need to do that. We need to necessarily investigate the modes of transmission for the 2022 outbreak. I can tell you from my cohort, a few of my patients I've seen in 2022, which were published in the preprint. Some have heterosexual transmission of monkeypox, but there's need to have more elaborate study to confirm this. And of course, we need to understand the natural history of monkeypox, especially now that it has spread to the global north and a lot of things about the disease is changing. We also need to be ready for medical countermeasures such as vaccines and therapeutics, and I believe that's part of the discussion we have today. So those are just a few brief presentation I have just to set the tone for the discussion. Thank you very much.
Thank you, Didi. Well, I think the fact that, Nigeria has not had access to the vaccines or the antivirals at this point is another example, unfortunately, of the really glaring health disparity. I think, one of the other issues we've learned with emerging infections, and this was certainly true of COVID, and we also know it was true of HIV when it emerged, is that the early period and the early response to a new outbreak are just critical. And you never get that early time back if you waste it. So I'd like to turn now to Greg Gonzalez and talk about the response to monkeypox thus far, that early period of the introduction into the United States, and how we did this again, right? We ended up with 1 million COVID deaths, one of the most affected countries, despite our fantastic science. And here we are with the largest number of monkeypox diagnoses. How do we get here?
So Chris and I, along with Ken Beyrer, who's at the Ramoy Community Health Center in Harvard in Boston, wrote a piece several months ago entitled "Deja Vu All Over Again." Right. So it is deja vu all over again. At the beginning of this outbreak in May, the White House COVID coordinator, Ashish Jha, former dean of the Public Health School at Brown, said, "We have the tools." So we have the tools, we know this virus, it's not an unknown virus, we have tests, we have treatments, we have vaccines, we will get a handle on this. We have the tools. Anybody ever tells you that in public health, be a little bit skeptical. Let's go through the tools. Testing. Beginning of the epidemic, we were told over and over again, we have enough testing capacity in the US. But yet we were having these test positivity rates that suggested there was gross underdiagnosis going around in the country.
Yeah.
Jennifer Nuzzo, who happens to be at Brown, Jay Varma, who was the leader of the COVID response in New York City, wrote a piece with the Washington Post saying, you cannot let state health departments do the testing for COVID, for monkeypox alone. It needs to be spread out to commercial vendors so physicians around the country can do this easily. It took months, weeks and weeks and weeks to get the CDC and the federal government to relent and allow commercial laboratories like Quest and LabCorp to do these diagnostics, right? We still have high test positivity rates. We know that we're not getting to the people who need to be diagnosed first and foremost. Let's talk about treatment. Monkeypox is an antiviral. We don't know exactly what its clinical benefits are, but in a country where we have millions of people uninsured, including vulnerable populations who've been hardest hit by this virus, saying that we have the tool and we have TPOX it is a little bit of an insult to the people who've been suffering over the past few months in this country. Chris talked about the morbidity associated with this virus, right? People are going into the hospital for acute pain, having to go on morphine drips to manage the pain. You also have to be in quarantine and isolation for 3 to 4 weeks with this virus. Nobody has sick pay. People are getting medical bills just for the symptomatic treatment, which they can't afford. So please don't tell me we have the tools. And now let's talk about vaccines. As Anne and Dima and Chris can tell you, we have 2 vaccines predominantly for the immunizing against the virus. But the most important one is a vaccine called made by a company called Bavarian Nordic in Denmark. The trade name is Genios. We've had a stockpile of it in the US. People have been banging on the table for months to saying, please scale up the supply. There are huge lines to get access to these vaccines around the country. In North Carolina, 60% of the people who are infected with monkeypox are African Americans. In this state, 27% of those getting vaccines in the state are African American men who have sex with men. So there is still a shortage of vaccines. And instead of scaling up the vaccine supply, the US said, let's cut the dose into fifths. And so what would have been given to you would be given to 5 of you as the vaccine strategy. And they said, we have the data. We know that this works. Again, as Anne and others will tell you, we have a very small evidence base on monkeypox in general. And in terms of the vaccine efficacy, we have scarce data as well. The head of the company, the CEO, freaked out. So what are you doing, cutting this dose in half? This wasn't studied like this. It wasn't approved for this. So to say we have the tools is a gross insult to what's been going on. And the one piece that we haven't talked about is that if we talk about scarcity of diagnostics and testing, the scarcity of treatments, the scarcity of vaccines, there are countries around the world who don't even have access to any of these at the current moment, particularly the endemic countries in Western Central Africa. There's a big piece in the New York Times this week talking about the case in Latin America where many of these technologies are out of the reach of countries like Peru and Brazil, et cetera. So how did we get here? Why did we wait for 7 years in the 1980s for President Reagan to give his first speech on AIDS? Why did we have over 1 million COVID deaths in the United States? And we still have 400 to 500 COVID deaths per day. And we've seen monkeypox cases go down in the US for the past few weeks. But a lot of that is gay men doing it for themselves, right? The CDC studies have suggested that there's been extensive behavior change in terms of reduction of partners and number of sexual encounters over the past few months. We can't rely on that alone, right? And so if Ashish Jha is going to, because we have the tools, it's up to us to get them into the hands of the people who need them. And this is the case for HIV, an epidemic that's still rated among us, malaria, TB, monkeypox, any of a number of diseases that are still with us. We always talk about neglected diseases, but we never say neglected by whom, right? And that's the crux of work on global health, because we can have the best medicine, the best vaccine, the best tests, but it means nothing unless the people who need them most get access to them as much as anybody in this room could have them available to them.
Terrific. I just want to say one thing for those of you who are not so familiar. This Genios vaccine is part of the toolkit of what Annie was referring to, developed for smallpox, right? And part of the problem with smallpox vaccines is that they're highly reactogenic and they were not safe in people with immunocompromise. So NIAID, actually, this was the US taxpayers paid for a lot of the development of this vaccine. It's a 2-dose vaccine. It uses a non-replication competent vaccinia, modified vaccinia ankara is the base of it. And so that it's safe in people with immunocompromise and in people living with HIV. In the US, about 40% of the documented monkeypox cases are in people living with HIV. And that is because we have a very high burden of HIV in the gay community and among other men who have sex with men. And so we have, in a sense, a syndemic. There also, as Dimi pointed out, that a number of the Nigerian cases were co-infected with HIV and also with syphilis. That is also emerging as a real function of what is happening with monkeypox here. And by the way, we have a syphilis epidemic. I mean, it's been going on for a number of years in the US. It is concentrated in the South and Southeast among African Americans, and particularly among sexual and gender minority men. You may also know that we recently also have had a major outbreak of neonatal syphilis, which we thought we'd almost gotten rid of in this country. So, and syphilis, by the way, is one of the few bacteria that has not shown any antimicrobial resistance. Plain old penicillin still works. It's curative with pennies. And it's a marker of health system failure. When you have syphilis outbreaks, you have a problem with your public health system. The US, of course, for those of you particularly who are not Americans and are new to the US, we don't have a public health system. We don't have a health system. You have a complex patchwork array that is state, local, county, national, and which failed us with COVID, and as we're seeing very quickly, is failing us again with monkeypox. I want to just maybe turn for a minute, and Annie, this would, I think, really come to you and then to Greg. I think we all understand that TPOXX as a therapy, we need data on. There is a trial underway now that's being supported. I think at least the data that we have on the efficacy of the Jynneos vaccine, by the way, this is all animal data because you can't do a challenge with smallpox, right? And smallpox has been eradicated. I wonder if you could speak to sort of the quality of the evidence for the Jynneos vaccine, what it would take to really understand better in the environment we're in, and also what you think the prospects are of getting vaccine to the endemic countries and to the other low and middle income countries that are facing this pandemic. And probably, as Greg alluded to, the most disproportionate burden with big cases and no vaccine is Latin America at this point, which looks like it's going to be the future of monkeypox.
Exactly. Well, that's a loaded set of questions there, Chris. And so I'm going to just start in general and say that, you know, what we know about the vaccines that are available is actually that they are safe vaccines. The safety data is pretty straightforward here. In particular, for the Jynneos vaccine, there was a study in DRC, very well tolerated. But you know, here's the thing about what we know about these vaccines. These vaccines there were very small studies outside of DRC, and in DRC it was for health workers who were wearing PPE and were very used to treating cases of monkeypox. And so doing a vaccine efficacy study in that population, also with a different clade of monkeypox, and the more we discuss the virus, the more I've been having this thought about how different these epidemics are. And it really, you know, in many ways, maybe comparing apples and oranges, you know, we can glean some things about what we know about the clade 1 that's been circulating for decades in DRC, but it may not be really applicable to what we're seeing. The different clade, very different characteristics in terms of presentation, in terms of all the, you know, we just don't have those data. So we've been doing a lot of comparison really based on the data from the 1980s, and then these, you know, kind of very small studies that have existed. The other thing that I have been very concerned about, and something that I've been thinking quite a bit about recently, is the issue that the data that we have for the vaccine is all based on this kind of household transmission and healthcare setting transmission, which is much more casual contact than sexual transmission. And so one of the things that I've been talking quite a bit about recently is the fact that we really just don't understand how well these vaccines are going to work in terms of preventing sexual transmission, which is really this kind of mucosal exposure, which is just, it's high titer, very intensive, repeated exposures, you know, potentially, that a vaccine isn't necessarily, this vaccine was not developed to protect against that. And what we do know from the data from these very small trials related to MVA is that it wasn't completely, and the challenge, you know, was a proxy study. So what they did was they vaccinated people with MVA, and then they challenged them with vaccinia. And it was not perfectly effective just in terms of those challenges either. So I think that we have to be people still got a lesion, right? It was a shorter duration of infection, but it did not prevent transmission. And I think one of the things that I've been hearing quite a bit about is that, and Greg brought this up too, I mean, people are, even a small lesion or a less severe lesion in the genital region can be just excruciatingly painful and require hospitalization, can be very psychologically damaging to people as well, and stigmatizing. And I think that there are so many different pieces here to unpack when we think about what these vaccines were meant for, how they were designed, and how we're using them. We just don't have enough information, but we're going to very soon, I hope.
Enormously helpful. I'm sure both Dimi and Greg would like to weigh in on that, but I'm just mindful of the time. We have about 15 minutes to go, and we'd very much like to open it up to the audience here and also to the folks online. We have about 75 people still participating online, which is awesome. Just because of the shortness of time, please do limit yourself to one question. I know that's hard. I just broke the rule. I asked Daddy like 3 at once, but just one question, and please do keep your questions brief, and then and let us know who the question is aimed to, if it's everybody or one of our 3 panelists. So please. Oh.
So very quickly, I was wondering, Greg and Chris, if you could comment on the role that you think the medicalization of our public health approaches have played in response to monkeypox as well as other.
So the question for those online is about the role that medicalization of the response may have played in the monkeypox response.
Well, Gavin and I were talking about this morning in the context of COVID. Your health is up to you in the medicalization response. If you have a problem, see your doctor, right? And Chris jokingly said we had no public health system in the United States, but it's not too far from the truth. This is an outbreak that we've been unable to contain, right? We have the worst outcomes, the highest mortality COVID per capita in the G7. So we think we have the tools, we have the most sophisticated healthcare system in the world, but we simply can't get our arms around HIV, COVID-19, or monkeypox. So that's where I think our medicalization and individualization of health in the United States has left us.
I would just also add, following on the point you made earlier, Greg, about community responses, that our best opportunity as a country to contain this monkeypox outbreak is while it's in our LGBT community, because we historically have not been a community with a lot of vaccine hesitancy. We have higher rates of immunization in LGBTQ Americans for COVID than in straight Americans. And as Greg said, and these data were out in the MMWR, actually from AMIS, the American Men's Internet Survey, that there have been significant behavior changes in the gay community that are the reason we're seeing declining rates, particularly in New York, which was the epicenter of the outbreak. So we still have a window, but I think one of the things that Dimi said that really gave me chills was that Nigeria has also seen prison outbreaks. Why is that a concern? Because COVID in the prisons and jails in this country became hugely disproportionate burden. And other infectious diseases like MRSA, methicillin-resistant Staph aureus, also began in gay and bisexual men, and now are really fundamentally, primarily a problem of incarcerated population. So that could happen with monkeypox, and let us please, get vaccine out and prevent that from occurring. Other questions?
We have one online from,
Please.
from Matt Boyce, who's a former MSGH alum, and he asks that Monkeypox as a select agent has been a focus of many preparedness simulations and tabletop exercises, but the response to this outbreak seems to have largely failed. If this is the case, what is the value, if any, in these type of simulations and exercises if their results are going to be ignored during response?
Well, it's a kind of a question and an answer. I will just say, and I'd love to hear what others think, but I think, you know, the mantra that we keep hearing is about how we're going to learn lessons, and we're going to have the lessons learned from COVID. And what you see very quickly was, for example, I think the single biggest problem with testing early on, which was, of course, the huge problem early on with testing for COVID, is that the CDC maintained the structure that essentially they were going to hold on to doing the definitive diagnostic tests. It's a two-stage procedure. The states were going to do a generic orthopox test, and then the confirmatory test had to go to the CDC. And the initial paperwork was taking physicians on average 3 hours to order a test. So, you know, in the middle of an outbreak, that's just not going to work. That's the kind of disincentive that stops people. And that means that we under-test. And you really are only going to test the people you think are the most likely to be positive and benefit from intervention. So those are lessons that have to go in the category of lessons unlearned. and systems not, you know, based on the evidence from prior outbreaks. Right? And, you know, we were on early calls with the White House. The White House, to their credit, they have an office of LGBTQ outreach, and they set up early calls reaching out to leaders in the community. Greg and I were both on those, a number of other folks. And people were pleading with the CDC to not maintain this burdensome, onerous, slow process and move quickly into commercial testing, and academic centers who, by the way, can stand up with, based on the CDC's PCR primers, monkeypox assays in very short order. Hopkins did that very quickly. So that, I think, is a signature failure early. Annie, are you responding to that, or?
Oh, I'm sorry, my computer froze for a second, but can you see me now or hear me now?
Yes.
Okay, perfect. So I'll just make this as fast as I possibly can. One of the problems in terms of these simulations is that we just didn't take into account this different kind of transmission. I don't think anybody ever really thought about this. And that was the hubris that we've had over and over again, not looking at the data that's being generated, for example, by DME. Who, you know, I mean, if we had looked at what was happening in Nigeria and then we had married that with what we knew and what we predicted just about monkeypox in general, I think we could have done a lot better with some predictions. And then the last thing I would say about that, because I've been involved in some of these modeling discussions, is that I think our biggest problem when it comes to modeling some of this and kind of trying to project this out is that we don't have a good estimate of vaccine effectiveness. We just don't. We have no idea, and we have no idea about the durability of immune responses. So I think it's going to be very important for any kind of tabletop simulations going forward and any kind of modeling going forward to do this with various scenarios, with sensitivity analyses, and really providing for all kinds of scenarios that are out there, which I think we've not been good at before. In the past, we said, well, we know about this. We're going to do this because we already know. So I hope that this issue of hubris is in future maybe tempered a little bit.
I wonder, Dini, if we could ask you to weigh in on that, because you showed data that I think shows pretty clearly that one of the big changes in the epidemiology with the outbreak in Nigeria is much more of this, both sexual exposure, sexual risk, but also focal lesions, genital, anorectal regions that really are also now the predominant presentation in other countries. And I think we still don't understand or have a good handle on what changed in that epidemiology. Yeah,
thank you very much. Just a few comments on the simulation. I think it's also important that simulation, apart from applying it to understand outbreak and response to therapeutics or medical countermeasures like vaccines, it also helps to ensure there's adequate readiness by health authorities or public health response teams. And it's important before simulations are applied in the epidemic response setting, it's important that stakeholders are involved, because sometimes if we don't carry along the stakeholders, you just do a theoretical work that is not practicalized in the field. But coming to the Nigerian outbreak, it was very, very unusual that we saw sort of a transition of monkeypox, a condition that was known to affect predominantly children, now affecting young adults, and most of them were males. We had not reported anal rectal lesions amongst our cases. Most of the cases had pure genital lesions, and of course, lesions at other sides of the body, the face and the limbs. But it was actually very remarkable that a substantial number of them had genital ulcers that looked like various forms of sexually transmitted disease, chancroid, granuloma inguinale, and the likes, and even syphilis. And that was what made it a bit perplexing and also very, very, very interesting. It's also a knowledge gap that we are not fully aware of the modes of transmission of monkeypox in Nigeria. I think it's an area that we need to invest more to identify how the virus is spreading, because it's almost very clear in the global north. The social group most affected is related to sexual activity, but we have not necessarily defined this in our country. Apart from the cohort we had in my center that had multiple sexual partners and some other related behaviors, we are not fully defined what is happening in the country, and I think it's an important area for us to invest.
Yeah, and I think, as we all know, of course, there are many countries where there are not legal and civil protections for sexual and gender minority people, and that makes this all the more complex. And it makes the stigma all the more complex because, of course, there are plenty of places where men, even if they have an anorectal lesion, are not going to share that information because it risks disclosure of sexual activity. And that really, I think, takes us into stigma. I don't know if you want to comment on that. Please.
And so I think you mentioned before the significance of early response, but there's always this dilemma of gathering enough evidence until you act. And I think there's always this gap until you do something about it. And I was just wondering if there's any protocol on how these organizations that really trust the public health response are supposed to act in that situation until you get evidence. I used to be an essential worker, and when COVID happened, we were all just looking up at CDC, waiting for some guidelines, but we didn't have anything coming in. And we just had to be our own advocates and trying to get gloves and I don't know, asking people to order from far away. But I was just hoping there was more structured protocol whenever that happened, because I don't think this is the last pandemic. But
That's probably a good prediction.
So, we like to think of public health as a technical enterprise, right? And that's what we come to school to study it. But it's largely political, because the people who make the choices are your mayors and your city councils and your governors. Some people in this room will remember an outbreak of a new strange disease in a hotel in Philadelphia before HIV, and the CDC sprung into action. How many cases were there of this new disease? Anybody remember what it was called? It became known as Legionella. Like, it became this huge, it was on the cover of Time magazine, right? So things have different valences politically. There are reasons that monkeypox, that COVID that HIV in the United States got responded to in the way it did. If you're looking for a metric when the alarm bell sounds, you'll have to ask the White House.
Please.
So we saw a lot of resources put into testing and tracing in the beginning of the COVID pandemic here. Before that was seen to be a fool's errand when we had widespread transmission. But I wonder if somebody can comment on what's happening right now with monkeypox and contact tracing, and if we, obviously knowing that's not the most primary prevention that we would hope for, but being that we have so many cases, what's going on with contact tracing, and what can we expect, if any, effect of good contact tracing in the situation we're in now?
I'm happy to take that one. I don't know, Annie, if you want to respond. Amy did allude to contact tracing in Nigeria, of course.
Oh, so the question is really about what's the benefit of contact tracing at this point, or is it being done? Which is the bigger question, because I would say that there's benefit to it, but the other problem with contact tracing in this context is that, we have a lot of anonymous exposures. We have the potential for asymptomatic transmission, prodromal transmission. So I think that some of it is going to be very complicated. Of course, it's important to have contact tracing if you can, but there are limits to it. So I think that the better way forward is really to inform people of risk. And we have the same problems. For example, we can draw upon examples with syphilis, for example, which and many other STIs, and there is a deep history of doing this work, and in particular in the affected communities right now. So I think that's the key, is drawing upon examples of what we've already done and thinking through how we can best move forward. But I don't think that we can rest on and say, well, contact tracing is going to take care of us, because it won't.
Dimi, did you want to speak to that?
Yeah, just to say that for the Nigeria context, and I believe for every other resource constraint context, there's always a challenge of contact tracing, and it relates to several factors. For instance, how people perceive the cause of disease. You'll be surprised that some people still perceive that this type of monkeypox is not caused by a virus. It's like a spiritual attack. And so to that extent, it becomes impossible for you to now look at contacts and ask them to come to the hospital, because if the household members believe that their loved one is under a spiritual attack, it becomes very difficult. And also the idea of this blame and stigma associated with sexual transmission itself is also a challenge, even for resource constraint setting, because once you link a disease with sexual transmission, there's a tendency for people to back out and be very reluctant to even tell you their sexual partners. And it's, even the so-called contacts or the sexual partners are even reluctant to come to the hospital setting. And so that's a challenge that I think clinicians, epidemiologists ought to address when they see cases and when they are doing the surveillance and contact tracing.
Yeah.
The only thing I'd say, Chris, we just did a paper on monkeypox and college campuses, which is relevant to
Yes, your bottling paper.
and it's out on a preprint, and there's a shiny ad. But the most important thing was getting people tested and into isolation. It wasn't vaccinated, it wasn't contact tracing, it's getting people to come forward for testing and to isolate. And so even on a college campus where you might be able to do contact tracing, that wasn't the big thing. It was getting people who were infected to come forward and to go into isolation.
I will tell you that, just quickly, that of the 4 pillars of the new national program to end the HIV epidemic, the 4th one is about what they call basically cluster busting, the idea that we're going to be able to use some new molecular tools to help identify clusters and outbreaks of HIV. And this has been met with resounding pushback from communities, because we still have so many states in this country that criminalize HIV transmission and criminalize non-disclosure. And you can imagine that, you know, if monkeypox becomes endemic, wouldn't be far off either. So we always worry when state legislatures get anxious. So this will be the last question, by the way.
We clearly identified lots of failures across the board. Are there any pockets of communities, of governments, of a town that's doing something right?
Yeah, well, I will tell you that I think New York State jumped into providing monkeypox vaccines in a variety of venues, getting out to the communities, getting out to pride events, to where the gay men and bisexual men were congregating. And you know, we don't know to what extent the vaccine program and the education program and the community-driven behavior change, how those account for the rapid declines, but the declines are real. So, and we know that because testing has actually been increasing, particularly since Quest and some of the other testing agencies are getting going. So we're seeing rising tests and declining positivity. So that's exactly what you want to see. So that is encouraging. It's also true that the Jynneos vaccine was stockpiled, as Greg mentioned, and we knew quickly that there was going to be a period of vaccine scarcity, and that has been being addressed. And so vaccine availability is increasing. And for those of you who are interested, there is monkeypox vaccine available in North Carolina as well. All right, well, we're at the top of the hour. I'd like to ask everybody to join me in thanking these wonderful speakers.